All right, good morning. It is April 6th, and this is Senate Health and Welfare. We're meeting this morning to hear testimony from folks on H353, an act relating to pharmacy.
Join the meeting.
Pharmacy benefit management. And then later on, we'll be looking at a couple of other bills that we've had in committee and possibly voting on some. So you know what, our first witness is Lauren Bodie. Is that right?
Bodie, thank you.
Well, thank you. Thank you for being here, and we welcome your testimony on H353. So why don't you go right ahead?
All right. Thank you so much. And I do appreciate you giving me the floor. As you see, I'm calling in from my clinic, and so my time isn't my own at the moment. But so I'm Lauren Bodie. I'm a pharmacist and also interim executive director of the Vermont Pharmacists Association. I am very grateful for the opportunity, very grateful to this committee for the continued discussion of this extremely important topic. So I am not a pharmacy owner, nor am I a dispensing pharmacist, so I have no monetary stake in the outcome of this bill. However, as a provider in a family medicine clinic who cares for people with diabetes, I see my patients caught up in this system every day. So to give you some examples, I want to tell you about the 4 patients I saw last Wednesday morning. So before I knew I was testifying in this committee, and before I knew who I was testifying with. So my first patient, Gary, was told by, and these are substituted names.
Lauren, I apologize for interrupting you, but as you're speaking, if you don't mind just slowing your pace down a little bit, because the microphone is not doing you justice.
Oh,
so,
is it not? Here, let me.
Yeah, so I think just if you just slow your pace down, it'll improve.
Is it better without the headphones?
Yes, it is.
Oh, just 1 minute. Oops. Sorry, let me try again. Is that?
That's much better, thank you. Right.
Okay, thank you. No, I appreciate you letting me know. So my first patient was Gary. So he's in his mid-50s, hard of hearing, struggles with maintaining his medical independence, and was really interested in getting his medications bubble packed so that he could manage his own medications as opposed to being dependent on someone else to do so for him. He was told by his insurance company that he had to switch to a mail order pharmacy, but that they could be bubble packed. When he asked about that though, and I looked at what mail order pharmacy he was required to use, and I saw that it was the mail order pharmacy of the subsidiary mail order pharmacy of the Pbm his insurance contracts with. They do not do these kind of services. So after talking with him, we were able to get him set up for bubble packs and delivery from Rutland Pharmacy. My second patient, Diana, has a hard time leaving the house because of her medical issues and the fact that she takes care of a grandson with special needs. But luckily, she has Medicaid. And so she can get her medications at a local pharmacy and delivered to her home. The third patient I saw is Nina, who grieves the death of her husband and so struggles taking her medications right now. When we talked through ideas and strategies, she too lit up when talking about the possibility of getting bubble packs. But she wanted to be able to get these closer to home rather than have them mailed to her. So I got her set up with bubble packs through Freedom Pharmacy. And then my last patient was Rosemary. She travels a long distance to come into clinic to see me because she lives in a very rural community. And she is blocked from filling at her local pharmacy that is just a couple miles down the road from her house. She has to travel 25 minutes to a chain pharmacy 2 towns over to get her prescriptions filled. So these are the 4 people that I saw last Wednesday morning. And this is actually a pretty typical day. in which I and my patients spend a lot of time and energy working around or working against the systems that PBMs put in place so that my patients can get care. It's a system in which currently the only way I can get care for my patients is by partnering with our local community pharmacies. And these are community pharmacies that are not going to be able to hold on much longer. There's been an independent community pharmacy closure every year I have lived in Vermont. In fact, 10 years ago, we had nearly 50 independent community pharmacies, and we're down to 16 today. So none of these were in areas that could afford to lose a trusted access point for healthcare. This was true before the pandemic, and it is certainly true now. So you'll hear from two pharmacy owners today about how PBMs are making it very, very difficult to care for patients. And I encourage you to remember that they are business owners, yes, but they are members of the community first. You're going to hear that this bill would substantially increase healthcare costs, but the data do not support this conclusion. I'm a scientist, I'm a data-driven person, and the data do not support this conclusion. In places where PBM legislation has passed over the last few years, health insurance premiums increased at rates below the national average. You'll hear opponents say that they only have the best interests of Vermonters in mind. And so I say if that is true, then being transparent about what they are actually doing should not be so objectionable. They'll say that they are focused on increasing the quality of care and reducing healthcare costs. And if that is true, then let them prove it in a transparent and responsible system that this bill would create. The reality is that PBMs are relying on the current lack of transparency to act without oversight and solely according to their own business interests. Furthermore, we do have an excellent example of a good actor in our Vermont Medicaid program that operates with transparency and fairness to patients and pharmacies. This is why years ago they moved away from operating with a PBM and instead have chosen a more equitable and cost-efficient model using a pharmacy benefits administrator instead. Much has been made about the complexity of this bill, implying that it is something beyond the scope of the legislature to be able to address. I do not dispute that these are complex topics, but I do dispute that this legislation is in any way propitious. The bill before you is the result of years of careful thought and consideration by national and state level experts, has been upheld by the US Supreme Court twice, relies on model language that has been carefully crafted by professionals at the National Association of Insurance Commissioners. On the House side, we also heard from the Department of Financial Regulation that the legislation as introduced is a holistic approach to the problems we are currently facing. And without effective regulation, PBMs will continue to act only in their own interest, not in the interest of Vermonters. And so I would ask that we continue now down this path to safeguard and expand protections for my patients, their constituents, and for all of us as Vermonters. I welcome any questions that you have for me.
Lauren, thank you very much. Do you have your testimony in writing that you can send to Aaron? That would be very helpful because your stories are very compelling.
Sure, I'd be happy to do that.
Okay. The questions for Lauren. I think we're going to try to move as quickly as we can through testimony. Our time is extremely limited, so we're going to be holding everyone's feet to the fire on time. And but if there are questions, go ahead. Okay. Thank you very much, Lauren. It's time for you to go back to work. But you're welcome to stay. You're welcome to stay with us if you have the time and interest. We're very happy.
I'll certainly try to, but I've got a lineup of patients scheduled. So thank you so much for the time, and I truly appreciate it.
All right, thank you.
Thanks. Bye bye.
All right. Take care. So Jen, I thought it might be helpful for the committee, just from your perspective, to get the 10,000 foot review of the bill, and then we'll go ahead with testimony.
Sure. Jennifer Carvey, Legislative Counsel. So H353 is an act relating to pharmacy benefit management and pharmacy benefit managers, which is often shortened to PBM. So that's the term you're going to hear throughout. It starts with an intent section in section 1, and then it makes in section 2, it amends existing statutory provisions relating to PBMs, including specifying on page 2 that the PBM has a fiduciary duty to its health insurer client, which is slightly different from the existing duty to act with reasonable care and diligence. There is a real requirement to be acting in the best interests of the party for whom you're acting as a fiduciary. So that's what the fiduciary duty is, including a duty to be fair and truthful, act in the insurer's best interests, and perform its duties with care, skill, prudence, and diligence. There is language that in the definition section that carves Medicaid out. You heard the testimony that Medicaid is using a different model. And so there, I think, would be some potential conflicts with some of the provisions of the statutes if Medicaid was not carved out. So the other main differences here, I know one that has been of confusion, so I want to some people, I want to make sure I highlight it, is on page 6 of the bill. This is new language saying that a PBM contract with a health insurer shall not contain any provision purporting to reserve discretion to the PBM, so claiming that the PBM gets to choose to move a drug to a higher tier or remove a drug from its drug formulary any more frequently than 2 times per year. This does not mean that if there are changes in the prescription drug marketplace that there cannot be changes made more frequently, but those would need to be done in collaboration and in agreement with the health insurer. What this is saying is there can't be a provision that says the PBM gets to unilaterally decide, that's the reserving discretion, to move the drug to a higher tier or take a drug off its formulary more than twice a year.
Currently, they can.
Currently,
they are able to change.
there's
that.
nothing, so this is talking about what can and cannot be in the PBM contracts. I don't know what is currently in the PBM contracts, but I would assume that at least some of the contracts do purport to reserve this discretion to the insurer or to the PBM on a more unlimited basis. And that's why the provision is easier, but you may hear about that from others. But I know there has been some of the talk about what may be expensive is if the formulary is kind of set in stone, other than 2 changes per year, even if there are changes in what happens with what drugs are available or what costs of drugs are. And as I read this, it's really looking at what the PBM can do on its own without the agreement of the health insurer client.
Thank you.
Below that is some limitations on what the patient has to pay out of pocket. So PBMs can't require them to pay anything more than the cost sharing amount under their plan or the maximum allowable cost for the drug. That's what the PBM is going to pay, reimburse the pharmacist for the drug, or the cash price. Other highlights to note here, and some of these are not entirely new provisions, but just moved and consolidated. So on page 8, there is an consolidation and expansion of existing provisions around what have been referred to as PBM gag clauses. Those are restrictions on what the pharmacist is allowed to talk about with the patient or others. So this says there can't be anything in the PBM contract with the pharmacist that restricts the pharmacy or pharmacist in any way from providing healthcare information that the pharmacist deems appropriate, including, and then there's a list of, again, some of these are in existing law, but some of these are new provisions. What else should I highlight for you? These are a bit more technical about the relationship between the PBM and the pharmacy. So just skimming through for some of the high points. There's some provisions around the pharmacy's ability to appeal and what some of the appeals processes look like. There are some provisions on page 12. And you may remember some of this from last year about, because part of what's not underlined on page 12 has to do with 340B drugs and PBMs and pharmacy programs. And we're extending the sunset on that toward the end of the bill, but there are also some other provisions about 340B contracts, trying not to disincentivize a pharmacy from participating or otherwise put any penalties on them for that. All right, what else should I highlight for you here? More on the appeals process between the pharmacy and the pharmacist. There are probably just some of the issues in the relationship between pharmacists and pharmacies. And then on page 16, this is the filling of prescriptions, and this is looking at existing provisions in our insurance statutes, but adding to them about where an insured person can fill their prescriptions. And this is in subsection D, giving the beneficiary a choice of where they're filling the prescriptions of any of the in-network pharmacies. And then there's a bit of a carve out for pharmacies owned or operated by a healthcare facility, because they may have some different financial incentives based on what services they offer at the facility. And then there are some other provisions sort of throughout here that talk about the state and OPR, Board of Pharmacy, being the ones who regulate the pharmacies and pharmacists and determine the scope of practice, and that the PBM can't layer on additional regulation about their scope of practice or what kinds of services they can provide that's beyond what the state regulators have determined. And then finally, section 5 is a DFR report, and this directs DFR and interested stakeholders to look at a number of additional issues. Some of these were in the bill as introduced. So whether there should be a license requirement, right now PBMs have to register with DFR, and the bill would keep that model in place, but looking at whether there should be a licensure model instead, whether PBM should be prohibited from doing spread pricing. If you're not familiar with that term, that's where the where the PBM reimburses the pharmacy for dispensing a drug an amount that's less than what they charge, the PBM charges the insurer for having paid for that drug, and then keeps that difference. So it's sometimes a very small amount on a per prescription basis, but as I understand, once it's magnified by volume, can be quite significant. Number 3 is in collaboration with the Board of Pharmacy, whether there should be any changes to the board's rules to reflect necessary distinctions or limitations on pharmacists' scope of practice. So should there be kind of different areas that pharmacists might specialize in or be allowed to do that not every pharmacist would be able to do without providing some evidence of training or credentials. Whether there should be a minimum dispensing fee. You'll hear, I think, a lot today about dispensing fees and their sufficiency or lack thereof. Some provisions around reimbursements for claims, for pharmacy claims when the pharmacy's appeal is denied. Whether there is a problem with pharmacies directly soliciting plan beneficiaries to market services. There's been a provision in the bill as introduced that would prohibit that, and this is sort of backing up and saying, let's look at whether that's an issue. And then any other issues about PBMs, pharmacies, pharmacists, and health insurance related to that. And the recommendations, findings and recommendations would come back to this committee and others by January 15th. And then finally, the new provisions around PBMs apply as plans are issued, offered, renewed, etc., on or after the effective date, but they will have 6 months to come into compliance if they are already acting in the state. And there's that extension of the 340B provision that you enacted last year. It's due to sunset currently on January 1st of 2023. This would expand it to April 1st of 2024, and the act takes effect on July 1st.
Okay, that's
Sufficient?
good. That's very good. We won't ask questions at this point. We just want to get, hear the testimony
Yes,
that we have.
absolutely.
Because we have exactly the right number of people for our next hour.
Great, and I need some play musical chairs as.
Yeah, and if you, it's up to you. if you can, it would be great to have you here, but it's.
I'm planning to be unless you would prefer that
Okay, all right.
I make room for others.
And I will have a question then also about white bag and brown bag that we wanted to attach to the bill as well.
Yep.
Yeah, okay, good. All right, so let's, thank you so much, Jen, appreciate it. Why don't we hear from Corey Duteau? Is that accurate?
Yeah, great job.
Good to see you. There we go, and glad you're here, so why don't you take the chair? Straight to the hot seat. And introduce yourself for the record, and then if you have written testimony, we would welcome it to keep with them, we can review it as we go forward.
Absolutely, and I'll be sure to send that in as well.
Sure.
My name is Corey Vito, and I own Freedom Pharmacy in Williston, Vermont.
Good now.
I've got to start here, Madam Chair, members of the committee. Again, my name is Corey Vito. I live in South Burlington, Vermont. I am the youngest of 3 brothers that are all pharmacists, as well as my father and numerous relatives. I own Freedom Pharmacy in Williston, Vermont, and we utilize specialized packaging to help patients manage their daily medications. We service patients from young to old, especially in the mental health demographic, and we deliver medications right to their doorstep. As you can imagine, this has been an amazing service for our patients and community these past few years with COVID. I am representing myself, and I support passing of this bill because without regulation of pharmacy benefit managers, Pbms, independently owned pharmacies like mine will be put out of business, and that will cause great harm to the community and the patients that we service. This bill in its original form is a step in the right direction to transparency of how Pbms operate, reimburse pharmacies, and get paid. It has amazed me for years now how every part of our industry is regulated, except the Pbms. The insurance companies are regulated, the manufacturers are regulated, the drug wholesalers are regulated, and pharmacies are regulated. How is it that the middleman, Pbms, are not regulated? It just doesn't make sense that all other spokes of this wheel are regulated except for Pbms. It is true that our industry is like many others and it is complex, but what makes it even more complex is that there is no transparency from the Pbms, which is exactly what they have worked very hard to achieve and maintain for decades. Along the way, they have profited in the billions, all at the expense of the taxpayer. Without regulation for Pbms, they operate as they see fit and without any checks or balances. Ultimately, this hurts the same patients that we try to help every day. Let me give you a few examples. Last week, one of our patients was discharged from the hospital at 4 p.m. The patient had been in the hospital for several weeks and was being sent home without their medications, which means they'll end up right back in the hospital. Our team put together the patient's medication pack, which included 2 antibiotics, and promptly delivered what was needed right to the patient's doorstep that evening. As you can imagine, our patient was extremely grateful because they knew that we were one of the only pharmacies that offered free delivery, and we did it late in the day when no other pharmacy was delivering. As I reviewed the time and effort that the staff put into this one patient's medications, it hardly made sense from a financial standpoint, as we were reimbursed a 50-cent dispensing fee on each medication, as well as pennies over our cost to acquire the medications, except on 2 medications, where we were reimbursed below our acquisition costs. In order for us to continue to be an important part of our community and our patients' lives, we need fair reimbursement from Pbms, which includes a proper dispensing fee. Another example that I want to share with you today really hits home on why Pbm regulation is imperative. Back in November of 2020, we ran into a reimbursement issue with one of our patients that has utilized our packaging and service for years. This particular patient is a young male that has HIV. He utilizes our services because our packaging keeps him compliant and taking his medications. We billed his medications as usual, but this time the reimbursement from his insurance was almost $200 below our costs. The patient is also a very good self-advocate and told us he was going to reach out to the insurance company to find out what was going on. Of course, because we are the community, we are part of this community and we care about our patients, we dispense medication at a huge loss, but inform the patient that we wouldn't be able to continue doing that one medication if this insurance didn't reimburse properly. The interesting part of this process was that there was a small glimpse of transparency of what was actually being charged to the insurance company by the PBM and what the PBM was actually reimbursing the pharmacy. We learned this because of the patient advocate who was told by the insurance company what they were being charged. Our jaws dropped. The pharmacy was being reimbursed under our acquisition costs while the PBM was billing the insurance for that same prescription hundreds of dollars more than what they reimbursed our pharmacy. This means the PBM was keeping the difference between what they billed to the insurance and what they shortchanged the pharmacy. Many states have begun to outlaw this PBM practice. Unfortunately, we are still not able to include this medication in our patient's package and have worried that the patient has been less compliant having to get this one medication somewhere else. In both examples, we did what every pharmacy on the claims that are reimbursed under acquisition costs, we appealed it with the PBM. Matter of fact, we have sent hundreds, even thousands of appeals to PBMs over the last several years, and 99% of them get denied. There are two main reasons that PBMs deny every claim. The first one is they respond in a vague manner, saying that they have determined that there is a cheaper alternative in the marketplace that we can order, or they say they've used a different reimbursement method which we cannot appeal. We send an appeal only after we search for cheaper alternatives from 9+ different wholesalers. And when we are unable to find an alternative that makes us whole, when we then ask the PBM to tell us where they're finding this alternative, finding this cheaper alternative, and we are told every time that they cannot provide this information to us. We would have no problem ordering this alternative medication that the PBM is using to deny our appeal. But the truth is, the alternative doesn't exist. The pharmacy should have a right to know the exact product the PBM is referencing in the appeal denial, but without regulations, the PBM will continue to evade transparency at all costs. PBM started out as simple claims processor back in the day when they charged a simple fee for processing the prescription claim. Without regulations, these companies have grown into billion-dollar profit centers using every tactic they can to get away with, including spread pricing, reimbursing under costs, clawbacks, DIR fees, etc. I love what I do. And I am part of a team of healthcare professionals that is proud to serve and be part of our community. We are embedded in our community. We support local organizations like Meals on Wheels, Youth Baseball, etc. I'm afraid that our pharmacy will see the same fate that so many pharmacies across the country and right here in Vermont have faced, which is going out of business. I like to think that I'm a fairly decent business person, especially having kept our pharmacy afloat for the past 8 years, all while facing growing challenges and unfair reimbursement from the PBMs. I'm not saying that the PBMs don't deserve the profit. What I am saying is that it needs to be done fairly and transparently. It's hard to run a business, keeping Vermonters compliant with their medications, keeping Vermonters employed when your business is faced with unfair reimbursement for products and services. I fear that a pharmacy like mine being forced out of business by unfair and unregulated practices by PBMs will create a medical crisis in our community. I ask today that you take a deep dive of what is being asked of you with this bill and do what is right to protect the community and the Vermont pharmacies that serve it. Thank you.
Thank you. That's very complete. Appreciate it. Unless there's a question of clarification.
Just a copy of your
Absolutely.
Yeah, we'll get, you can send it to Aaron, and we'll electronically.
Absolutely.
Thank you for your time.
Thank you for having me.
Yeah, perfect. I'm very happy that you contacted me.
I do have just a quick question. How
Yes.
long has your pharmacy been in existence?
It has been Freedom Pharmacy since 2013, and we bought it from previous owners that started it in 2002. So we were about 20 years collectively. A lot of the employees were with the previous owners, myself included.
Thank you. All right, thank you. Thank you, Corey. Jeff Hochberg is here. Good to see you again.
Good to see you, Madam Chair. Thank you for having me. Thank you, the members.
And so far, we're very good about our timing, so
I fear I
It's all
might invoke
yours.
some questions.
All
So thank you, Madam Chair. Thank you, committee, for having me here today. First, let me say thank you to Representative Mari Cordes for first introducing H353 and getting it this far, along with Senator Hooker and fellow committee members who co-sponsored a companion bill on this side. This bill is absolutely necessary, and it is dire that we take action immediately, because the situation is just that, it's dire. So for the record, my name is Jeff Hochberg, president of the Vermont Retail Druggists. And I did share a slide presentation for you that I'd like to go through. I don't know if Aaron put it up there or not yet. That I think highlights some of the testimony that you've already heard today from Dr. Bodie and Corey, who just spoke about the issues. The VRD recommends that the committee take a hard look at the bill as originally introduced and reconsider some of the language that was stripped in the version that came out of the House, particularly around the dispensing fee and spread pricing, along with any other protection measures for Vermont consumers in maintaining access. Again, the original language was drafted from a model language from the National Association of Insurance Commissioners, and Jen Carvey, our left counsel, took it upon herself to help to take all the various pieces that were already in existence in Vermont statute, comprise them together into one vehicle, and try to supplement that fit that within that model so that it can best align with best practices. So with that said, I'd like to go into a few things to highlight exactly what you heard about today from other people. The PBM space is dominated by three players: CVS Health, Cigna, United Healthcare. They are all publicly traded corporations. They are vertically integrated. Insurers, PBMs, and pharmacies, they own all. Together, they control 80% of the industry. Their combined annual revenue exceeds that of the entire medical expenditure of France. France was voted in 2000 by the World Health Organization as having the best healthcare system in the world. And yet the PBM's annual revenue exceeded their entire expenditure. The FTC is concerned. Recently in February, they began taking public testimony as to the effects of PBM managers on patients and pharmacies alike, and are proposing a 6B study into their actions. Will regulations raise costs? It is something you will hear. The question is where is that information coming from? Who's determining that? What has been studied by the National Community Pharmacy Association is that in states with PBM regulation, licensure in particular, the growth of healthcare expenditure has slowed compared to that of the national average. In Vermont, you've heard that we have an issue of access and pharmacy closures. Between July 19 of 19 and November of 2021, Vermont saw a loss of 18 in-state pharmacies, 12 of which were independent pharmacies. There was something that's been highlighted in other testimony is that there's best practice model for us to look at and use as a comparison, and that is Vermont Medicaid. Largely led by Nancy Hogue, who I think you're going to hear from later today, who now represents the Shield. There was a lot of changes that occurred in the last day. In 2004, there was 2 reports issued by the Government Accountability Office and HHS Office of Inspector General determining a change to its payment methodology to promote transparency and the appropriateness of drug payments. And the rule directed two relevant changes. One, it addressed the collective finding that states were overpaying for drugs because they were using commercial drug pricing guides. And two was to evaluate whether the fees they pay pharmacies are adequate and compensate them for their cost of dispensing the prescription. And they redefined dispensing fees to actually include the pharmacy's costs. So those are the two main issues: spread pricing and the dispensing fees that we largely ask you to reconsider as language added back in. What's interesting is that at that time when Medicaid when CMS rather issued that rule change, Leslie Norwalk, the acting administrator, commented that the total pharmacy revenue for prescription drugs will decline by less than 1% with this new model change. So rather than adding costs, it was saving money, and it was transparent. Dispensing fees are inappropriate. Non-affiliated pharmacies are forced to accept contracts with Pbms that pay little to nothing as a professional dispensing fee. No other professional would ever survive with the professional fees and the rates to which Pbms reimburse pharmacists.
Madam Chair, can I ask a question of clarification?
Yeah,
at the
sure.
moment?
Yeah, go ahead.
So dispensing fees are something that the PBM charges pharmacists
They
to,
pay pharmacists.
Pay the pharmacists.
they pay the pharmacist to dispense the
Yes.
medic. Okay, so I'm confused. Is a payment to you as the pharmacist to dispense the drug that the PBM is saying is the one that you need to use?
Yes, the pharmacy, every transaction that a pharmacy goes through, every drug that they dispense, the pharmacy earns a dispensing fee for that claim.
So it might help if you have some slides.
I have an example here. and
I'm looking at
Oh,
the
you are?
I am looking
Okay.
at slides, but I'm trying to understand the,
So when we submit a claim, you come into a pharmacy, the pharmacy looks at your prescription, make sure it's safe, make sure it's appropriate, and bills your insurance company. Okay, and by billing your insurance company, it doesn't bill Blue Cross Blue Shield, it bills Optum RX, or it bills Caremark in the case of MEP. That's done electronically, that's done instantaneously, and what comes back is the PBM contract rate for the drug, along with a dispensing fee in some cases, not in all cases, sometimes it's zero.
okay,
And that's the pharmacy's only mechanism of revenue, apart from over-the-counter sales.
oh, okay, so, I'm sorry if I'm not understanding it, but, so you're, as a pharmacist, I'm trying to understand why as a pharmacist you don't like the dispensing fees, because they're insufficient or because
They are insufficient, yes.
but you wanna get rid of the dispensing fees?
No, what we want to create a structure around dispensing fees that ensures that the dispensing fee is appropriate, that it's reviewed on a regular basis,
I see,
and that it's incorporated back into consideration for the global rate filing and the impact to consumers directly.
Okay. So what I was hearing from you is you wanted to get rid of dispensing
Oh,
fees,
no.
but what you wanna get is have fair dispensing
Fair
fees, okay, that's a helpful clarification.
Yeah, go ahead.
And currently, it's the PBM that's setting the dispensing fee,
Correct.
and you would rather have someone else.
Correct.
Go ahead, Senator.
Yeah, thanks. So I'm very supportive of the bill and what you're looking to accomplish. So I start off by saying that, but and full disclosure, my pharmacist happens to be your pharmacy. So, but you know, you guys have millions of dollars in expenses every year with the building, the staffing, insurance, everything else. You're making 8 cents, 10 cents, 29 cents a dispensing fee. How are you staying open? Is it the compounding you guys do? Is that where the money is? It's not from selling chips and sodas in the front of the store.
So it's complicated, but it ties into.
We understand that
It's
concept.
been a slow decline in profitability for sure, and it's it's an absolutely
I'm
dire
not, and I'm not looking
situation now.
to analyze your books.
No.
It's not my business, but to me, I'm like.
What
okay,
happens is,
8 cents I get an inhaler from you every 3 months.
Correct.
It's 8 cent dispensing fee or whatever the quarter say. You gotta sell a lot of inhalers to pay the pharmacist with their salary and everything else and keep the lights on. And so I'm just trying to, it doesn't, the economics of running a pharmacy, it doesn't make any sense to me right now.
so my banker says too. It is volume driven. 100% volume driven. It is ensured that it maintains a volume driven by the three titans who control the volume. If you do not do a substantial amount of volume, you will fail as a business owner in this state. Here. There's also the issue that there is a difference between what is billed to reimbursed rather on a drug by drug basis. So it's, a recent study was done by 3 Access Advisors where 80% of the prescriptions filled by community pharmacies are filled at low margin, meaning that they're filled at a gross revenue of less than $5. There is that other 20% that's out there that is high margin drugs. These high margin drugs, high cost drugs, go by other monikers, and that business is largely steered back to subsidiary entities owned by the Pbms. So the ability for a pharmacy to stay afloat has become increasingly desperate as the lion's share of equitable business is steered back to subsidiary entities. That makes sense. Let me give you an example here. Paxlovid is the oral antiviral used to treat COVID. Okay. It is acquired through the State Department of Health. It is disseminated across the state to pharmacies willing to participate. There is zero cost associated with this medication, which is why it's a perfect example. There is no margin to be had on the product. It is a purely service-driven transaction. Pharmacy submits a claim for a Blue Cross Blue Shield patient to get COVID, the oral antiviral for COVID. OptumRx reimburses the pharmacy 8 cents. Never mind that this drug is extremely dangerous. Never mind the hours of work it might take to acquire all the different medications of this patient because it might not be your patient. So they determine the appropriate dispensing fee as 8 cents. Just by submitting the claim electronically, the pharmacy already incurs a 7-cent transactional fee with its switch provider, which is just a data processing between us and the PBM. Several weeks later, Optum then submits its weekly paycheck to the pharmacy. In that, and per their contract, they claw back 29 cents as a claim processing fee. The state of Vermont then collects 10 cents as an assessment to fill every prescription, applied to every prescription filled within a pharmacy in the state of Vermont. At that point in time, the pharmacy's gross profit on this drug is negative 40 cents before it gets into the HR costs, before it gets onto the general expenses for the facility, or the cost of the bottle. That doesn't cover the ink cost to print out the label. It is absolutely important that that is the system that we live in today. And it's why pharmacies are close to consumers.
And go ahead.
Nice. So just so I can get a better understanding of the margin growth that you're looking to increase here, what would be an acceptable range that you folks feel that you should be reimbursed? Obviously, it's not 8 cents. What would an expectation be of the money that you would like to see back for something of this service?
The expectation is that we create a process to which the dispensing fee is regularly evaluated. CMS rule around Medicaid's dispensing fee, which today sits at $11.13. There's a big delta that's going on between what they determine to be fair at this point in time and what Optum determined to be fair. But that be reviewed annually. That'd be a part of the rate considerations for premiums, as pharmacy represents a largely growing proportion of the overall healthcare expenditures. I think today it's somewhere in the 30% range. So why are we not taking a look at what's going on in the pharmacy? And we need to make sure that we have adequate access because there is added cost.
So Jeff, what I'm gonna suggest is that your comments then, because we're moving into a crunch time here, and we have other folks to hear from, to maybe focus on the bill itself and your comments in support of or changes to the bill, if you could do that very briefly.
Absolutely.
And then we'll move on to Sarah Teachout.
So in terms of the bill, again, we asked that some language be reintroduced for an appropriate dispensing fee to be determined. And that by our accounts that it should be based upon, it should be no less than the Vermont Medicaid established rate. If it is less than the Vermont Medicaid established rate through this, as determined through a substantially vetted process, then Vermont Medicaid ought to be lower, paying less. So again, it creates a system of checks and balances. We want to ensure that you take a hard look at spread pricing. Spread pricing is a tool to which Pbms use to conceal the truth as to the true cost of pharmaceuticals. It should not be incentivized as to which products are being dispensed. We should be incentivizing services, quality service, as opposed to drug selection. Again, that also goes back to the discretionary capabilities of Pbms to add or remove at will pharmacy or prescription drugs from the formulary. Arguably, that could even be a violation of current state law with discretionary clause prohibition. It's never been looked at legally, but I think we should explicitly put in there that they should not do it any more than in parity with open enrollment periods, because people choose their insurance plan largely based on the drug products they use. So why should we create an issue? Spread pricing is also consumer harm. And some of my slides, which I didn't get to, really, I think, highlight how consumers are harmed because of spread pricing. If the maximum allowable price that a PBM determines to actually be appropriate for a drug is less than the amount that the patient pays when they're in the deductible, then the patient is overpaying. Not only is the insurer paying because they're paying that inflated price, but the consumer is paying when they have the high deductible, they're paying out of pocket. So again, everything in the original bill was about transparency, it was about ensuring equity in terms of access and care for Vermonters in this state. And we should revisit all those things. We should definitely focus on licensure and create proper authority. I would encourage the committee to also consider having a discussion around network adequacy, which the NAIC group is attempting to discuss in its upcoming spring meeting. For example, one of the stores that closed during COVID was Woodstock Pharmacy, which I believe was the oldest pharmacy in the state of Vermont until 2020 when it closed the stores. My group worked with Maliskutney Hospital to open up a pharmacy in the town, and that happened on July 2021. To this date, I still do not have an answer to our application for inclusion in the networks of several PBMs. They purposely delay the application process. It even flat out says that it could take up to a year to be included in the network. At which point in time, the network has already changed. Every time that the PBMs are threatened with oversight, they change their contract structure. We need to have a regulatory body at the helm with full powers to properly regulate and oversee their actions. I would also encourage the committee to include an explicit private right of action to pharmacies to help combat this. It will take DFR a long time, even if the bill is passed in its original form, to properly oversee these market players. And pharmacies at this point in time, it's unclear as to whether or not they have legal capabilities to even go after them.
Okay.
So with that.
We have all of your suggestions in either your slides or the written testimony?
Yes.
Because your written testimony is very short,
Yeah.
but your slides are more inclusive. Okay. this is helpful.
It's
And you're
very-
not going anywhere today, so.
I will be
we can come back
around
to you
for
with
any
questions. Good, all right. We do want to hear everyone, and we have our limited time.
For sure, I totally
It's our
understand.
life,
It is.
right now. This is our life.
Well, I thank you for the time that you have given, and I will hang around for any questions.
Yeah, no,
that there
thank
is.
you very much. Really appreciate it. It's been very educational, among other things. Oh, good. Yeah, all right. So Sarah, thank you for being here with us, and we look forward to your testimony.
Thank you, Senator Lyons and members of the Senate Health and Welfare Committee. I'm Sarah Teachout, the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. And I have with me Nancy Hoke, who you all know. She joined Blue Cross only a week ago, but she certainly has a lot of experience in this and I think can offer information that would be helpful, especially when we want to compare to the Medicaid program. I have limited my comments to what is in the House passed bill. If you'd like to take up some of the provisions in the original bill, I think I would have a number of additional comments and it would take a bit longer. But I did try and keep this short and to the point. So I did submit testimony. It is in writing, I believe, on your webpage. And so to begin with, H353 has the twin goals of protecting the remaining independent pharmacies in Vermont and limiting pharmacy benefit managers from using drug cost management tools. While having good intent, this will have negative consequences by increasing the overall pharmaceutical costs for consumers here in Vermont. So I will specifically go to page 6, it's section 2 on formulary management, and it begins with a little E just to put you there. Blue Cross must be able to adjust the formulary based on developments in the prescription drug marketplace. This is the key to our ability to encourage generic substitution and implement other formulary management tools that push down the rising cost of premiums. So I know Vermont spent a long time developing our generic substitution laws that allow for lower priced generics to be replaced with brands. In order to get people to change their drugs, we need to have incentives for them to do so. And I love the term status quo bias, which is an economic term that means people generally don't like change. So by prohibiting the ability for us to change our formularies when new drugs come onto the marketplace, we are not able to maximize the ability to do that and to encourage people to make generic substitutions. There's other pieces in here, and I could spend a long time on formulary management. We need to be able to remove drugs from the formulary if they are deemed unsafe by the FDA. There's a whole number of things that happen. My understanding is that this language is intended to allow additional formulary modifications outside of our contracts, but that really needs to be clear and explicit. We don't change the formularies to irritate providers. We change them because there's a lot of new drugs on the marketplace and we need to be able to keep up with the latest research and developments. So I would ask if you want to keep this in that the language is made clear. I think that the extra explanation from Jen Carabee was helpful, but we can't leave it up to the extra explanation of the intent. We need it to be quite clear. So I'll move on to the next section that we had comments on, which is page 7, the next page. I believe it's all still section 2, and this is little f2. This is amounts paid to be attributed to the deductible. So this is about manufacturer coupons. Manufacturer coupons are used to offset patient cost share as a means of incentivizing brand drug selection over lower priced alternatives, which in turn drives up overall pharmaceutical costs and premiums. Mandating that these amounts be attributed to the deductible is an additional inducement for patients to choose higher cost prescriptions with a false sense of savings. So that is a choice you're making if you would like these to be applied to a patient's deductible. If that's the policy choice you make here, we need it to indicate that these, in order for these to be applied to the deductible, the information must be provided electronically in a manner that is integrated to our pharmacy claims benefit system. The administrative cost to process paper claim submissions and refunds is prohibitively expensive and not operationally feasible. We process millions of claims every year. So then I'm going to jump to section 4, which begins on page 16. So this is essentially a prohibition on maintaining a specialty pharmacy network. This is the most problematic portion of the bill from our perspective, and we request that you remove this section of the bill entirely and study these complex issues prior to making policy decisions that will result in significant cost impacts to Vermonters. Both the exclusions, and you'll see them there, of the healthcare facility-owned pharmacies and the Medicaid program from any of these provisions should give you pause and is an indication of the potentially negative consequences from these provisions. If Medicaid can't afford it, Vermonters are left paying the ever-increasing premiums, certainly can't either. So I'll talk a little bit about our specialty pharmacy network. I think to give this section justice, you would need to get into what is specialty pharmacy, what is a specialty pharmacy network, and a lot that I don't believe that we have time for here. But we maintain a specialty pharmacy network that includes local specialty pharmacies. This network serves all of our members and meets high quality standards for safety, patient care, and value. Specialty pharmacies are focused on delivering optimal care through efficient patient care plans to achieve desired medication therapy outcomes for patients with complex, often chronic, and rare conditions. Eliminating our ability to manage the network of pharmacies that provides these medications with specific standards and requirements will harm our members and drive up costs. So briefly, Blue Cross, I have some data and I can share it with you later. About 1.9% of our scripts in a year are for specialty pharmacy drugs, but they amount to 55% of our total drug spend in a year. So we're talking about very, very few prescriptions for enormously high cost drugs. The average cost of a specialty pharmaceutical drug is over $6,000. And that's the average, which doesn't do justice to the highest priced ones. Let's see. So there's a lot of provisions around specialty pharmacy, and there is also a very recent legal case between MVP and Rutland Pharmacy that was decided on March 16th, and I'm happy to share it with the committee. I believe that is a lot of what this particular section is about, but it would impact Blue Cross and our ability to manage specialty pharmacy drugs. So because these drugs require special care, special handling, almost always they have prior authorizations on them. They need to be kept at certain temperatures. They have special care coordination. Oftentimes lab work needs to be paired with the drug for the patient. We don't believe that allowing any pharmacy to deliver specialty drugs is good public policy. So I will stop there. I don't think that does that section justice at all, but I realize you're under some time pressures. So I'll turn next.
Yes, this is great. We have 2 questions for you, and
Okay.
I do see in your written testimony comments on the brown bagging, white bagging, which we will utilize as we go forward with that section of the bill. It will be appended to the bill, so that's very helpful as well. And so Senator Hooker and then Senator Terenzini.
Thank you, Sarah. So Sarah, currently, who determines who the specialty pharmacists are?
Right. So currently we create a specialty pharmacy network, and we have a set of standards and an application to be included in that network. It includes credentialing and a bunch of other provisions, which are actually in your S42 242 brown bagging bill. Every single one of the provisions ironically, that you are mandating in that bill, you're eliminating in this bill. So it's kind of interesting. And so I don't know if I've answered your question, sorry.
It's Blue Cross that is overseeing this, the applications, and who's allowed to be the specialty pharmacist.
Correct. And we do have a network created by Optum, our PBM, and it includes local specialty pharmacies as well.
And
Predominantly ones at hospitals.
Thank you.
We're getting some conflicting signals, so after we may reach out to folks after your testimony so we can get to a dialogue. Senator Karanzini.
Yeah, thank you. Sarah, before Senator Hooker's question, you made a statement and it was like the punchline statement of your paragraph. What was it again? You do not support what?
Oh gosh, I had a few of those.
There's something about specialty pharmacists.
Well, we actually think you should remove this whole section of the bill. I'm sorry, I'm not remembering exactly what my statement was. I do want to comment a little bit on some of the other things that were talked about specific to the COVID drug prescription refills, and as well as how pharmacies make money. I realize that's not in the bill, but because you got into that previously, I think it bears a few comments. So our dispensing fee for COVID drugs is $10.50 is my understanding. So maybe we need to have a discussion with Jeff, but the fee is higher because we recognize that there is no margin on those drugs, that they're provided directly by the federal government and paid for by the federal government. And that's why the dispensing fee looks more like the Medicaid program dispensing fees for those. It's not really comparable what Medicaid gets to do compared to commercial payers. Medicaid pays far less for the drugs than a commercial payer does. And so they have higher dispensing fees. We pay more for the drugs and have lower dispensing fees. And I have specific examples I can send to the committee later on that. And just a quick minute on spread pricing. Spread pricing is the difference between what one entity acquires the drug for and then what they're able to sell the drug for. I like to give a simple example before I get into the drug space. So your grocery store practices spread pricing. They acquire your strawberries from the wholesaler for some amount, say $4 for a bin of strawberries, and then they sell them to you for $4.50 or $4.25. I don't really know grocery store margins. That's spread pricing. And when the price of strawberries goes up in January, for us here in Vermont, we don't blame the grocery store for the increase in price. We blame the wholesaler because they're flying them up from gosh knows where, Mexico or somewhere. So then to turn that back into what's happening in the drug supply chain. So the pharmacy acquires the drug from the wholesaler for some price that we don't know what it is. And then they are reimbursed for that drug by the PBM. So the difference there is what the pharmacy can make on spread pricing. And my understanding is it is more difficult for pharmacies to make a large spread. Then there's another spread, and that is between what the pharmacy is reimbursed by the drug for the PBM and the amount that the commercial health insurer is paying the PBM for the drug. That's another spread. So the proposal in the original bill was to eliminate the second spread, but not the first one. And if you want to get into spread pricing, we could spend a lot of time on it. But I think ignoring half of the equation doesn't do this justice either. So if you'll allow me, Senator Lyons, I'd love to get into the brown bagging, white bagging, clear bagging, home infusion topics. I really wouldn't want you to attach that bill without hearing from us.
Go ahead. Why don't you just take a couple of minutes because we do have your testimony in writing on that, but go ahead.
Okay. So I did send you some links to, it's kind of an interesting website called drugchannels.net. I'm not sure what their source is for their information. but they're not kind to any player in the drug supply chain. They are equally critical of PBMs, insurers, hospitals, and 340B pharmacies, as well as manufacturers. So I think it seems like a pretty unbiased source of information. But Blue Cross essentially opposes all of the provisions contained in S-242, the brown bagging, white bagging, and home infusion prohibitions bill. This bill prevents health insurers from managing prescription drug costs, and this is really about specialty pharmacy and convenience for our members, but allows provider-owned specialty pharmacies to utilize these exact same tools without limitation and with the identical methods of drug distribution. So let me just step back and tell you, if you don't know already, what is brown bagging, white bagging, and clear bagging. So brown bagging is when a specialty pharmacy or a regular pharmacy delivers the drug directly to the patient's home or directly to the patient wherever they are. And that's the sort of image of your brown lunch bag. White bagging is when the specialty drug is delivered to the provider from the PBM or the health insurer's specialty pharmacy network. Clear bagging is when a hospital-owned generally, but it could be another provider-owned specialty pharmacy delivers the drug within their own or to another provider in their network. So those are kind of equivalent. It's just where the drug is coming from. So a hospital may send it to their outpatient center. They may send it to a home infusion site. They may send it to another clinic, but it's the identical method of distributing drugs. So this bill is about protecting hospital specialty drug profits to the detriment of patients, and the cumulative profits for drug sales at Vermont's hospitals is enormous. As a health insurance provider, Blue Cross is responsible for managing the care and costs of our member and customer pharmacy benefits. Providers do not have that financial obligation to their patients. In fact, they may have the opposite incentive. And this is a quote from that website, drugchannels.net. Physicians who are employed by a health system can be mandated or encouraged to send patients to the health system's in-house pharmacy. Steering prescriptions and referrals to in-house medical care have become common among hospitals. And I think that also includes health systems. Requiring the insurer who has the responsibility and risk for the pharmacy benefit and the resulting premiums to negotiate the source of the medications with the healthcare professional, and that's defined in the bill, who may stand to gain financially from where the prescription is filled is not in the best interest of patients. This applies to all of the prohibitions included in S-242, and I talked through them: white bagging, brown bagging, and also this home infusion at home or at an infusion site. So most hospitals, this was another quote from the exact same article, and there's a couple other links. It's a pretty interesting website. Most hospitals can earn extraordinary profits by acquiring discounted specialty pharmacy drugs under the 340B drug pricing program. That's because operating an in-house specialty pharmacy allows a hospital's pharmacy to capture the full value of the difference between the reimbursement paid by patients and their commercial or Medicare Part D plan, and the drug's discounted price provided by the manufacturer to the hospital. And there's a link there for more information.
Sarah, thank you. So we are going to have to go through that section another time, but we appreciate your comments. And we're also going to have to check through with the conclusion that you've made that we're putting it in one place and taking it out another. So that'll be something. Our biggest concern with S-242, of course, is patient safety. And we're also concerned about not eliminating the 340B process, which is so critical, I think, to a number of folks. So appreciate your very much appreciate your input on all of this. I think we're going to have to move on at this point, unless there's a last question. I saw Senator Hooker or Senator Terenzini.
Well,
Okay.
Seems to me that what you're talking about, Sarah, with the clear bagging stuff, sounds a lot like what PBMs do with directing consumers to their companies, but that's a different discussion, I guess.
So I concluded by saying there's many perverse incentives in the drug supply chain, but the provisions in this bill exacerbate the issues and it's the patient who ends up losing.
Well, we don't want that to happen, and we're going to take care to understand the provisions of the bill. But we also feel very uncomfortable about the lack of transparency that currently exists in the drug pricing process. So that continues to be a huge concern for us, and we want to move forward. So Senator Party.
I just want to make sure, are we gonna get more testimony on the brown bagging? I
Yes.
mean, we have gotten no testimony on it.
Yes.
I don't know that a decision has been made
Yes.
to attach it.
We're going to
the
get testimony.
bill. I don't think we've taken a vote on that.
We're going to take this.
Okay,
Okay.
it's a different.
So, and it's important, I think that, you know, as long as Sarah was here and she had heard our conversation the other day, that she had responded to that bill. Okay, other questions of clarification? Okay, well, of course, this is a complex issue, and we do appreciate that. And we also appreciate the different positions that folks have within the drug pricing industry. The worst part for us is not knowing what the price is. And we know we know it's complicated. We understand that. We've worked on this previously. So we'll continue our efforts.
Can I ask?
Senator Hardy.
Yeah, Sarah, are you still there? Can I ask you a question?
I'm still here.
The section 4, what you call the prohibition on specialty pharmacy network.
Mhm.
And maybe this is a question for Jen, but I don't see that actually in here. So,
Well, so I can try and pull up the section of the bill, but it's the part that says that a patient can go to any provider. It's sort of a combination of that, along with there can't be any limitations on a pharmacy beyond what the state of Vermont's pharmacy board decides. So it's the combination of those two pieces together. And Nancy, have I said it well?
Yes, and sorry, Nancy Hogue, I'm the pharmacy director for Blue Cross Blue Shield Vermont. As Sarah said, I've been here a very, very short time and still learning and understanding the differences between Blue Cross and Medicaid. But in any event, Sarah, yes, there is a provision in that bill that prohibits the establishment of classifications of drugs. So we interpret that as meaning you cannot classify a drug as a specialty drug versus a traditional drug. And by virtue of that prohibition, that would, disallow us from managing a specialty drug network and a specialty pharmacy network. I also, if I could just point out one more thing, Sarah is extremely articulate, thankfully, and she's carrying the day today. I did want to point out that all of the specialty pharmacies in our network, which again includes the hospital pharmacies, are accredited. And the accreditation standards, there are several accrediting organizations. The two most prominent are what's called URAC, which is the Utilization Review Accreditation Commission. And then the other most common one is ACHC, which is the Accreditation Commission for Healthcare. But in any event, and then there's two other accrediting organizations as well. They have very, very strict standards for accrediting these facilities, everything from customer service, dispensing, packaging, shipping, patient monitoring. And I'm happy to share those standards with the committee if you think that would be helpful in understanding, how carefully, I guess, those pharmacies operate and what standards under which they operate. Thank you.
Wouldn't those standards also mean that another pharmacy that's not a specialty pharmacy have to adhere to the same standards for the provision of what you're calling specialty drugs?
No, so a traditional pharmacy would not need to meet those same standards.
What
I
you
mean, they
just
would
said they
have to-
apply to all pharmacies, that's a contradiction.
These are specialty pharmacy accreditations, so they're specific to specialty pharmacies.
Okay,
We'll have to sort that one out, as I'm seeing some head shaking, and this will become probably a debatable issue for sure. Senator Terenzini.
So, two questions quickly. Nancy, is a specialty pharmacy would be, say, Rutland Pharmacy versus Walgreens?
Yes, well, Rutland does both. You know, they do traditional and specialty drugs. But yes, that's one example.
Okay. And my next question is for Sarah and Chuck, if you don't mind. Chuck, are you still with MVP?
Yeah.
He's gonna testify.
Yeah, okay. So Sarah and Chuck, where would Vermonters go to see the net profitability that MVP and Blue Cross has made on Vermont insured patients year in and year out? Is there a website that Vermonters can go see the net profits of your companies?
Yes, so we submit all of our financials to the Department of Financial Regulation every single year. I wouldn't call them profits because we're a nonprofit, but there is margin and losses every year. And I do actually, gosh, I just provided it to someone recently, but I could certainly send you what our financial results were for the past 3 years.
I appreciate it. Thank you.
Okay, other questions for Sarah or Nancy? Senator Hooker.
Yeah, just going back to the specialty pharmacies, Nancy, if a pharmacy complied, if a pharmacy applied and had all of the standards covered, then they would become a specialty pharmacy, and then consumers would be able to choose that pharmacy based on, you know, the fact that they are you know, they're meeting all of these specifications, or are you limited through your insurance as to which pharmacy you can go to? I mean, I can see not, you know, maybe not saying every pharmacy is open to these consumers, but if they apply and meet the standards, then are they then allowed to be in the network?
That is my understanding, yes. Sarah?
The answer is yes, and that's actually what the lawsuit between MVP and Rutland Pharmacy is about. But yes, if you meet the standards and the national accreditation, you can be in our pharmacy network.
And with regard to knowing, you know, looking at the records for the insurance companies, what percentage of the premiums is based on drug costs?
It's growing every year. I'm trying to think of it. So I don't think I can answer the question off the top of my head. I might have to email you, but just so you know, there's retail drug costs, which are the cost of drugs that you go and get in a pharmacy or delivered from a specialty pharmacy. And then there's medical drug costs. So those are the ones that you get in the hospital that are usually part of the medical spend. And so that's often oncology drugs and other special drugs that you get in the hospital. So when you add those two pieces together, that's how you get our total drug spend. And it is growing at a double-digit growth rate. And it's driven by specialty. But I will get you the exact amount because we include that in our rate filings every year.
Okay, I think we probably should move on to Chuck Starrow and then Stephen Larrabee. And we'll probably pick up our S69 discussion a little bit late, maybe 10 minutes after or quarter of. So Aaron, just for the heads up, and let those folks know where we'll sign, which is okay. Chuck, thank you for being here. And we have your testimony, and Nancy and Sarah want to say thank you. I think I said it before, but I'll say it again. Appreciate your time and your effort and bringing us your information. Chuck, you're here, so please go right ahead.
Thank you, Madam Chair and committee members. Chuck Storrow, Leonine Public Affairs, here on behalf of MVP Healthcare. MVP is a nonprofit health insurance company headquartered in Schenectady. It provides health benefit plans for approximately 700,000 people in New York and Vermont, of which Vermont is about 40,000 people. MVP is one of only two health insurers that provide health benefit plans to the small group and individual market in Vermont. I will, just picking up on Senator Terrazini's questions, I'll reiterate what Ms. Teachout said in terms of the company's financials, but I would also point out that the company's rates for health benefit plans for the individual and small group markets are heavily regulated by the Green Mountain Care Board. It's an annual rate setting exercise that involves an in-depth analysis of the healthcare costs and the trends and what is needed by way of rates to cover those costs, and what is needed in order for the company to have adequate reserves to deal with contingencies involving a spike in costs. So there's really no analogy to a regular for-profit company. Having said all of that, MVP acknowledges that Pbms and the issue of Pbms and their relationship with health insurers is a legitimate topic of public policy. However, this area is very complicated and involves many different considerations and is tricky. And there's a potential for unintended consequences in terms of increasing costs. Basically, Pbms do provide a valuable service valuable services in a number of regards, and are critical in countering increasing prescription drug costs, which are a major driver of healthcare costs and health insurance premium increases. A lot of it is, somewhat a good thing because the manufacturers have come up with extremely important and valuable drugs that can treat previously untreatable conditions, but they're very, very expensive. And so it all has to be considered very carefully in order to balance the value of these drugs versus the costs. And of course, the pharmacies are a critical key or a player in all of this, and they're important to the system too. In the interest of time, I am going to focus on Bill Section 4 on page 16 of the bill as passed by the House. That section would amend Section 4089 j of Title 8, which is the so-called, as it stands right now, mail order parity statute. Essentially, that statute provides that a retail pharmacy can fill a script for maintenance drugs that would otherwise perhaps be filled by a mail order pharmacy, as so long as the patient's out-of-pocket exposure is the same as what it would be the case if they got those drugs from a mail order pharmacy, and so long as the amount that they get reimbursed is the same as what the mail order pharmacy gets reimbursed. The sections, the additions to to that statute set forth in subsection D, which is what Section 4 would enact. I'm not going to go through them all. I'm going to focus on subdivision 3 as being particularly problematic in two regards. It prohibits Pbms and insurers from establishing classifications or distinctions between prescription drugs, and it goes on. But that creating these kind of classifications is sort of the foundation of the whole prescription drug benefit system that health insurers provide, and in particular, I'm going to mention the drug formularies that the PBMs and the health insurers develop, which essentially create tiers. There's tiers and drugs are placed in these various tiers. And the difference is basically the amount of copay or out-of-pocket exposure people will have if they obtain a drug that's in a particular tier. And what that is all about is that there's more favorable, i.e. less out-of-pocket exposure for lower cost drugs that are effective from a therapeutic point of view. For instance, generic drugs versus branded drugs, or therapeutically equivalent drugs that are less expensive than another type of drug. As you probably are all aware, the drug manufacturers are pretty relentless in their advertising of drugs. And so there is a predilection on part of many people to want to get the brand drugs. And the formularies are designed to provide an incentive for people to get the lower cost drugs. And I don't think it's the intention of subdivision 3 to really upset that, but based on its plain language, that would, that could potentially do away with that whole formulary system, which is a beneficial aspect of trying to contain prescription drug costs. The other part of this, and this goes to the specialty drug issue, is this section and also subsection 2 sort of basically says, hey, if a pharmacist is licensed by the state of Vermont, they should be able to do anything and everything in the world of pharmacy. And that, and that on the surface, that's a legitimate sort of position to take. And it is also true that there's no sort of defined definition of what a specialty drug is, but generally speaking, they're recognized to be very expensive, complicated drugs used to treat complicated chronic conditions, and often involving, being administered in a healthcare setting. So there is a recognition of sort of the unique nature of specialty drugs, and as I said, they're extremely expensive. So while a pharmacist's licensure may not have a particular sort of like additional credential related to specialty drugs, because of their nature, there is an accreditation process that Ms. Hogue mentioned about being able to handle specialty drugs that is important to patient safety and well-being. And there was reference to a litigation involving Rutland Pharmacy and MVP, and that was over the issue of Rutland Pharmacy's ability to dispense and be reimbursed by MVP for specialty drugs. The company basically denied their ability to do that because they didn't feel that they had been credentialed. And I will submit the court's decision, which just came out in mid-March on that, in which the court granted MVP summary judgment and dismissed the case. And really what it came down to was Rutland Pharmacy was claiming that the requirements that MVP wanted to impose in order to allow Rutland Pharmacy to dispense specialty drugs were a pretext for favoring MVP's Pbm, which is CVS Caremark, which operates a chain of drugstores. But the court noted that requiring credentialing by URAC or these other agencies that Ms. Hogue mentioned was a legitimate tool on the part of MVP, and so this would.
We're hearing a court case now, and I think it would be important for you to continue your comments on the bill itself, and
Sure.
You'll have our ledge counsel work with us to understand the implications of any court case. So thank
Certainly,
you.
I understand, Madam Chair. The reason I just mentioned that though is that what Bill Section 4 would do, this subdivision 3 would obviate the ability of a company like MVP to impose a credentialing requirement upon pharmacies relative to their ability to handle specialty drugs. And all I'm saying is, as the court said, that imposing that credentialing requirement was a legitimate.
Okay, well, we'll get to the court case, but
So that,
because what I'm hearing you say is that MVP is interested in credentialing pharmacists for prescribe or issuing or selling specialty drugs. And so that's the issue right there. I don't want to get us into a debate on any court case at this time. Thank you.
certainly, and yes, MVP is, in fact, does require that type of credentialing on the part of pharmacies in order to be handle specialty drugs, and it feels that that's a legitimate position to take, and that it's important for patient safety that ability to do that be upheld, and this bill would undo that, would prevent them from doing that. And so therefore, we do feel that it is problematic. We acknowledge that, as a matter of state pharmacy law, there is no sort of special treatment for specialty drugs in terms of the pharmacist's license, but given the nature of them and the fact that they've really only sort of come to the fore in the last 10 years, this is an evolving area that is a legitimate concern on our part that we'd be able to maintain that credentialing requirement. And it's open. It is not something that it's only certain pharmacies can seek credentialing. If a pharmacy that's otherwise in network can get that, then they can well be able to dispense specialty drugs.
Okay, I think we're getting tight on our time, and we do have your testimony in writing. And we appreciate your taking the time to go through that, the sections that you have gone through with us.
And I thank you for your time, committee, and
We appreciate your time as well. Thank you very much. So, we're gonna, unless there are questions for Chuck at this point, Senator Hardy and then Senator Hooker.
Yeah. Chuck, are you
Who's there?
still there?
I am. Sorry about that. I'm actually testifying 4 times today, so I'm sort of like a little bit distracted, but go
I hear
ahead.
you. So on the bottom of page 16, paragraph 3 that you were just talking about,
Right.
where can you point to where it says that you would not be able to require a pharmacy to be credentialed?
That's a very good question. It's difficult for me to point to that. It's really a matter of subdivision 2 and subdivision 3 basically saying that if you're licensed under state law and federal law, you can do anything and everything. So it's kind of doesn't actually specifically mention credentialing, but because, as I explained, there isn't a specific certification to a pharmacist's license relative to specialty drugs. The net effect of this would be to prevent us from imposing these additional credentialing requirements above and beyond what a pharmacist has to get through their licensure.
Okay.
It's a nuanced set of language, Senator. I acknowledge that, but that's that from our perspective is would be the result.
Okay.
So it's a, okay, I'll talk to our legislative council about it.
Yeah,
I don't see that, so I'm just confused. All right.
Yeah, we'll have to sort that one out. It's a good question, Senator. Senator Hooker, one last question, then we're going to
Just
move on.
quickly, so with regard to overseeing who can become a specialty pharmacy, do you have an opposition to the Board of Pharmacy doing that, or where do you see that?
You would apply to the, well, first of all, you have to be authorized by the insurance company in its PBM to handle specialty drugs, and what they do is they would look to a variety of factors, including accreditation by these outside organizations. So if you want to do that, you would want to be for the lack of a better term, URAC accredited. You would need to understand what the requirements that the PBM and the insurance company have in this regard, and then you would have to do it. And if you do it, it's applied neutrally, and you can obtain it.
That doesn't sound, that sounds like the PBM is making requirements above and beyond accreditation and state licensure.
Doesn't sound.
They're making requirements above and beyond state licensure, but those requirements include being accredited by these objective outside entities.
But they include that, that means that there are other requirements.
Right. So Senator.
Right, but they're applied equally to any pharmacy that wants to meet them. So it's not a matter of only.
But presumably some pharmacies, it's easier for them to meet them if they're in your network. Is that true?
No, not necessarily, Senator. I mean, Rutland Pharmacy is in our network, but they're not authorized to dispense specialty drugs by or be reimbursed by MDP for specialty drugs until they meet further requirements that are applicable to any and all pharmacies.
Senator, I'm going to suggest that this is a really important point of discussion, and we're going to have to move into that with Ledge Council to fully understand what the bill is saying, and then our own decision making. You've asked the bottom line question. That's very good. We got it. So let's move on to Stephen Larrabee. And Stephen, we've got 7 minutes. I know that you were prepared for 10, but we'll, our time is precious. So please welcome to committee and thank you for being here.
Thank you. And just as a housekeeping, can you hear me okay before we start?
Yeah, no, terrific.
Great. So Chair Lyons, members of the Senate Health and Welfare Committee, my name is Stephen Larrabee. I am Director of State Government Relations for CVS Health. I'm really happy to be speaking with you today. I am a Danville, Vermont native, and it's always a pleasure when work brings me back to my home state. This is my first time testifying before this committee, and I look forward to working with you all on this legislation and in the future on other issues. Unfortunately, I'm here to speak in opposition to the bill, which, as you've heard, will increase the cost of medications for patients in Vermont. As with previous hearings in the House, I'm concerned that the members of the legislature are left with the impression that PBMs serve an illegitimate purpose. And I can assure you that couldn't be further from the truth. There is no doubt that the prescription drug system is complex, maddeningly so. But PBMs exist to help our clients and patients navigate this complex system. The bill before you includes a number of provisions that have real impact on the ability of health plans and PBMs to manage prescription drug costs. And costs are really important here because we know that when patients can't afford medications, they become less adherent, which leads to worse health outcomes and higher costs across the board. Unfortunately, the bill may be as complex as the prescription drug system, as it includes a number of separate provisions, each of which deserve careful attention. We've been talking for quite a while now, and I think we've really only touched on a handful of sections within this 20-page piece of legislation. And so while I think the House was very collaborative in its deliberations, the looming deadline for crossover did seem to cut short a lot of needed conversations about these separate provisions. And so I think that's why the House acknowledged that at least some of these pieces needed to be kicked over for further study and needed more review before becoming law in Vermont. Our primary concern is consistent with those you've heard from Blue Cross Blue Shield and MVP, which is section 4 of the bill, appearing on pages 16 and 17. As was noted, the underlying section of Vermont law, section 4089J, allows licensed pharmacists to fill prescriptions in the same manner and at the same reimbursement level as they are filled by mail order pharmacies. And so there's this kind of like same terms and conditions and same reimbursement level paradigm to ensure that mail mail is treated at parity across pharmacies. Subsection D, however, which is added by the bill, states that patients must be allowed to fill prescriptions at the network pharmacy of their choice, and that the cost sharing differential between the pharmacies has to be consistent. Unlike subsection B in the underlying statute, there doesn't appear to be any limitation. So instead of a mail retail parity question in the underlying statute, this section could apply to mail, retail, or specialty pharmacies. And there's no similar requirement that reimbursement has to be the same. Generally, we have concerns with sections like this because broadly the policy cuts against what's happening all over healthcare. We incentivize patients to use lower cost settings. So in health plan formulary design, or health plan network design, for example, you might have tiered networks in order to use lower cost providers, or you might have site of service cost sharing differences between the hospitals or freestanding or at home care, right? I'm not sure why we wouldn't treat pharmacy in the same way if there's a cost savings to members to use one pharmacy over another. Further, I'm concerned that patients today who use home delivery will be and are billed currently a lower cost sharing amount as an incentive to use mail order, right? Typically it's some smaller amount than the 30-day copay amount. We would be prohibited from providing that incentive to use mail order pharmacy under this bill. This appears in the last sentence of D1 on the bill. It says it cannot impose a cost sharing differential. So those cost sharing differentials, typically again, for getting a 90-day supply home delivered is usually a lesser cost sharing than if you pick up a 30-day supply 3 times at a retail pharmacy, right? I also want to just emphasize again in subdivision 3, or in paragraph number 3, states that PBMs and insurers may not establish, quote, classifications of or distinctions of drugs, or place restrictions on pharmacies that are more stringent than those set by state, federal, or the Vermont Board of Pharmacy. We agree with the insurers' interpretation that this is intended to target specialty designations for drugs. It would be nice if the language was explicit, if that is the intention, but I think you'll notice throughout the bill, there's quite a few places where there's some broad language that is left open to interpretation, but we agree that the intent here is to target specialty medications. This would have a significant impact on all health plans, as I'm almost certain that nearly every health plan issued in Vermont has a specialty tier in their formulary design. And many of those health plan products, as you've heard, has a limited network of accredited pharmacies to dispense those medications. As you've heard, specialty medications are unique in that they are extremely expensive and they drive healthcare spending and therefore premium. So in the United States, we spend $500 billion on prescription drugs, roughly 6.3 billion prescriptions. As Ms. Teachout noted, and this is consistent from what their experience is to what's happening nationally, 2% of prescription drugs dispensed are specialty, but they account for like 54% of cost. Just for reference, generics make up roughly 90% of dispensed drugs, but account for 20% of the cost, and brands make up the remainder. And I'd also note that we're talking about a fairly limited, extremely limited number of drugs. There's roughly 20,000 approved drugs in the United States, and roughly 750 or so are considered specialty. Just from CVS's perspective, I would also note that our latest drug trend report came out recently. Across our clients, we held prescription drug cost growth trend to 2.3% in the aggregate, but specialty trend was 5.3%. So I think if you think about this, and I don't want to play armchair actuary, it's very likely that drug trend for non-specialty was negative year over year, but specialty pharmacy drove prescription drug spending as an increase year over year. These sections if these sections are intended to apply to specialty pharmacy, it would make Vermont an outlier among states. So while states have discussed expanding pharmacy networks, those that work in specialty pharmacy are typically required to match the same terms and conditions, i.e. accreditation, as other specialty pharmacies, including the reimbursement. It would also create different rules of the road for managing specialty medications than is used in the state's existing Medicaid program, which designates specific specialty medications, limits the network of specialty pharmacies that may dispense such medications, and requires all such specialty pharmacies to be accredited by independent agencies like URAC. So Medicaid today does all of the same things in Vermont. Medicaid in Vermont does all of the same things today that we're discussing here. And lastly, I think Ms. Teachow's point is really important. I know we're not here to talk about 242. We hope to testify on that in the future, but it does seemingly conflict with the provisions of 242 because that bill speaks to how patients and providers act with specialty pharmacies to receive medications administered in medical settings. We completely agree that section 4 should be removed and included in the further study to make sure that there aren't any unintended consequences here and that the costs for these medications can continue to be managed by health plans until we make sure that the language is drafted appropriately to achieve its desired policy goal. I just wanted to quickly, there's a lot of other provisions, but I did want to echo a couple that were mentioned earlier.
Steve, what I'm going to ask, Steve, thank you. I think if we don't have anything from you in writing, so what would be helpful is for us to have your testimony in writing and including your final comments on the other sections that you were beginning to reference. And we'll, and if need be, we will certainly get back to you to fully comprehend your comments on the bill. But at this point, we're going to have to end our testimony on the bill itself. So, so we greatly appreciate your time and would ask that you send your written testimony into Aaron, including what you have already provided to us this morning. So thank you.
Senator, I would just close by saying thank you. This is an extremely complex issue. I hope there's many more meetings on this bill that we can discuss some of the nuances of try to get you some language in writing.
Yeah, unfortunately, we don't have the luxury of time. And to be quite honest with you, this committee has reviewed and looked at Pbms in the past, and we don't lack an understanding, but we understand it is very complex, and we do appreciate the comments that you brought to us. So we're going to switch gears. We're going to take a 2-3 minute break now, committee. We're going to go off YouTube, and then we'll come back.